Consider you have a patient at your OPD and he's complaining of chronic irritation in his eyes, as well as when you examine that patient, you come across a watery discharge that is coming out of his eyes. You can consider to be him suffering from viral kind of a conjunctivitis, which is basically a venereal conjunctivitis that can be known as a venereal conjunctivitis. Our today's lecture comprises of viral as well as granulomatous conjunctivitis cases. So these are the different presentations that you can come across when you're running an OPD, when you are running an IOPD. You can come across these viral cases as well as these granulomatous infections that can occur in the eyes. The causative organisms that are responsible for the viral cases are mostly the Herpes Simplex virus 1 and 2, and then we have the adenoviruses that are mostly responsible for such a presentation. The granulomatous infections can be the chronic infections that can be they can be viral in their origin, as well as they can be bacterial in their origin. So it's basically the chronicity that is giving way to this granulomatous kind of a presentation in an individual. So over here, the viral kind of conjunctivitis, if we just summarize the causative organisms that are responsible for the viral kind of a conjunctivitis, it is the adenovirus conjunctivitis, which is the most commonest kind of conjunctivitis cases that we usually come across. Then we have the herpes simplex keratoconjunctivitis cases. These keratoconjunctivitis, the word or the terminology that is the keratoconjunctivitis, it means that it is involving the cornea as well as it will have its effects on the conjunctiva as well. On cornea, we usually observe the patient to be having the corneal opacities, the corneal ulcers, or it can even lead to the complications of corneal perforations in these patients. As well as when we consider the conjunctiva to be involved in the herpes simplex virus infections, it is the chronic irritations that can occur at the conjunctiva, at the limbal junction of the cornea and the conjunctiva, as well as a foreign body sensation. The discharge that will be involving this kind of a herpes simplex keratoconjunctivitis cases would be mostly a watery kind of a discharge rather than a purulent discharge that was noted down in the bacterial infections. So this is the mainstay of differentiation between a bacterial and a viral kind of a keratoconjunctivitis case when we are looking at it clinically. Then obviously we have the other viruses. For example, we have the herpes-zoster conjunctivitis cases, which can be basically involving it can be basically the underlying cause for the viral kind of conjunctivitis. Then we have the molluscum contagiosum conjunctivitis. We have the poxvirus conjunctivitis. Then we have the mixed virus conjunctivitis cases. We have the paramyxovirus conjunctivitis. And on the other hand, we have the arbor virus conjunctivitis. So there is a strain of conjunctivitis. These are the different ranges of the viruses that can be responsible for the development of viral conjunctivitis in a patient. Again, it's very important whenever we are considering that this particular patient is suffering from viral conjunctivitis, we'll have to isolate that particular virus from that purulent discharge that the eyes are creating. It's again the culture sensitivity that we'll be performing in these patients, and that will basically highlight the factor that which of these viruses is the underlying causative organism in that particular case that we are clinically dealing with. Then obviously the two major modes of clinical presentations that usually occur in these cases of viral conjunctivitis are the acute follicular conjunctivitis. Obviously, these follicles are more prevalent or they are more evident on the palpebral part of the conjunctiva. When we'll be everting the lids, it can be the upper lid, or most commonly, it is the lower lid that is everted in these individuals. We'd be observing these follicles that are present on the palpebral part of the conjunctiva. And that is basically the evidence that this patient is suffering from some sort of a viral conjunctivitis. So this is the most common presentation, as you can appreciate over here, even in this picture. Then we have the acute hemorrhagic conjunctivitis. So it can be that we have this scary picture of the acute hemorrhage that has occurred on the bulbar part of the conjunctiva. So it can be one of these pictures, or even it can be the coupling of both of these pictures. We sometimes in a lot of patients, they would be suffering from the hemorrhage as well as they would be having these follicles on the palpebral part of the conjunctiva. So these are the two major clinical presentations that we would be observing, and in these patients, when we would be examining them on the slit lamp, it would be very easy to observe that they also have a watery kind of a discharge on the lower lid, rather than a mucoid or a mucopurulent discharge that was the basis for the bacterial kind of a conjunctivitis that we'd already observed and that we'd already discussed in detail. So this is a particular differentiating feature between the bacterial kind of conjunctivitis, and then we have a viral kind of conjunctivitis at our hands. Then considering the etiology, so what are the causative organisms and how are we going to study? The most common viruses that are responsible for the production of this viral kind of conjunctivitis is the adenovirus. It is the strain that is almost 80 to 90 nanometers in size, and that is the most common strain responsible for the production of the adenoviral conjunctivitis in the patients. We have the penton capsomeres. This is a very important characteristic of the adenoviruses. They have these capsomeres, it has their protective properties, and it is how they are causing the replication of these viruses. The hexon capsomeres are also present as the outer covering in these viruses. They are unenveloped, double-stranded DNA viruses. You have to remember this. And then we have these capsomeres and these penton capsomeres. We have these hexon capsomeres that are providing the outermost covering for these kind of adenoviruses in the patients. The viral genome is the central part for these adenoviruses that we usually come across, and the clinical parts of the adenoviral conjunctivitis, or the clinical types of the adenoviral conjunctivitis, they basically comprises of the epidemic keratoconjunctivitis, which is the most common presentation, and it is an epidemic that usually occurs in a lot of communities. Then we have a non-specific acute follicular kind of conjunctivitis. We have the pharyngoconjunctival fever, which is another clinical variant for such adenoviral conjunctivitis cases. And then we have the chronic relapsing adenoviral conjunctivitis cases. So it can be a recurrent and relapsing kind of a condition in a lot of patients. And sometimes it is due to a dormant kind of an infection that is prevailing in one of the eyes, that is basically responsible for this relapsing and recurrences of such kind of a clinical picture. Out of these varieties, the epidemic keratoconjunctivitis is the most commonest variety that we usually come across. First of all, we have to educate the patients regarding this kind of an epidemic keratoconjunctivitis. We have to give them education regarding the personal hygiene for the prevention of such epidemics that usually occurs in the communities. So the personal items, the use of the personal items, for example, the sharing of the towels, the handkerchiefs, and the sharing of the bedding is responsible for such kind of the spread of the epidemic keratoconjunctivitis cases. In these epidemic keratoconjunctivitis cases, if they are left untreated, it can involve the cornea of the patient, and sometimes it can be very vulnerable for the patients. If it causes the corneal ulcerations, it can lead to corneal perforations, and that would be a debilitating situation for the patient, resulting in a decrease in the visual acuity of the patient. So we have to prevent these complications to occur in patients of the epidemic keratoconjunctivitis cases. Then running across the etiology of the epidemic keratoconjunctivitis cases, we'd be going through the adenoviruses type 8 and type 19 that is responsible, and that is the mainstay for the epidemic keratoconjunctivitis cases to occur in the patients. So these are the types that are most notorious for the development of these epidemics in the communities. The symptoms for the epidemic keratoconjunctivitis would include the redness and the watering, that is the watery discharge. It won't be a mucopurulent discharge that is coming out of the eyes. Mostly it is just a thin watery discharge that is coming out of the eyes, and the patient would complain of redness that has occurred. Obviously, it's not a hemorrhage. It's just the redness that is occurring due to the chronic irritation of the eyes. Then it would be followed by the mild mucoid discharge if it is the superimposed bacterial infections. So sometimes it's just not an isolated picture of viral conjunctivitis. Sometimes it is coupled up by a superimposed bacterial infection, and that would lead to the mild kind of a mucoid discharge that would start oozing out of the eyes. Then the patient would also complain of ocular discomfort and photophobia. So the patient would basically complain of, he would be having the phobia of coming out in the sunlight. And then the patient would also complain of a foreign body sensation that he has in his eyes. It can be due to the trichiasis, due to the entropion, and it can be even the cicatricial entropion that is responsible for this kind of a foreign body sensation that is occurring in the eyes of the patient. Then obviously, once you have taken the history from the patient and he has given you the complete details of the complaints that he's having, he would be again giving you the conjunctival signs. If you'd ask the patient to sit on the slit lamp examination, these would be the conjunctival signs that you would come across in the patient. Foremostly, you'd be looking at the hyperemia, that is the redness, and the chemosis that is occurring in the eyes. It can be at the limbal junction, and even it can be at the peripheries of the bulbar conjunctiva. Then moreover, the patient would be having the follicles of varying sizes. He or she would be having a papillary reaction that would be occurring in the eyes. And then the petechial and the subconjunctival hemorrhages that you'd be observing in the patient. Lastly, the patient can have a pseudomembrane in his eyes. So it's the last, and obviously it can be included in the complications as well. Lastly, the patient would be suffering from such kind of a pseudomembrane. So this chemosis, these follicles, the papillary reaction, they can be manifested more easily when you evert the eyelid. You would be observing for these follicles, for these papillas to be present on the palpebral kind of the conjunctiva. Then obviously you'd be looking for the petechial hemorrhages, which was another important presentation of the viral kind of conjunctivitis, and you'd be looking for any formation of a pseudomembrane on the conjunctiva, or even it can involve the cornea of the individual. Another variant after the epidemic keratoconjunctivitis, the signs would include the superficial punctate keratitis. These are the variable signs that we can observe in the patient. Then the patient can have the subepithelial infiltrates. Obviously, there would be the inflammatory changes that has occurred in the eyes, the infiltrations due to the inflammatory cells that have infiltrated subepithelially, as well as the epithelial microcysts that would develop at the bulbar and the palpebral part of the conjunctiva, as well as the cornea can be involved as well. Preauricular lymphadenopathy is very important. It can be the submental lymph nodes and the submandibular lymph nodes that can also be involved in these cases of the epidemic keratoconjunctivitis. Now, how would you make the differential diagnosis in these patients is again very important. You should know it is sometimes quite a confusing picture. How can you distinguish a viral kind of an epidemic conjunctivitis from a conjunctivitis of a bacterial origin? So you have to differentiate this epidemic keratoconjunctivitis from the acute haemorrhagic kind of conjunctivitis, from a non-specific acute follicular conjunctivitis, from pharyngoconjunctival fever, herpes simplex virus and the other viral conjunctivitis cases, and as well as the adult inclusive conjunctivitis. So these are the range of confusions that you can have whenever you have a patient and you think that this patient is suffering from epidemic keratoconjunctivitis. You have to differentiate them from all of these clinical conditions. Now, the tests that are usually performed for the differentiation are the cytologies that are carried out, the immunologies that are carried out, and then we have the cultures that we can perform for such patient, and we can isolate the exact organism that is responsible for this keratoconjunctivitis that is occurring in a patient. We have the PCRs that can be performed for such differentiations, the point of care immunochromatography tests that are performed. We have the viral cultures to isolate the organism that is basically a double-stranded DNA organism that is responsible for the production of such keratoconjunctivitis cases. Then we have the conjunctival cytology that is done with the GIAMSA staining for such keratoconjunctivitis cases, in which we are considering that the adenovirus is responsible for the production of this epidemic keratoconjunctivitis. Then obviously the treatment guidelines. So we have to be quite sure that this patient is suffering from a viral kind of a conjunctivitis. We usually provide a very supportive kind of a treatment for these patients who are suffering from the epidemic keratoconjunctivitis cases. The treatments would include obviously the cold compresses, and as the patient also complains of photophobia, you'd ask the patient to use sunglasses for such kind of a photophobia. Then obviously decongestant eye drops would be advised for the patient. We'd also advise the lubricant tear drops, because sometimes it is the complication of this viral kind of keratoconjunctivitis. It goes on to be called as the keratoconjunctivitis psycha. So psycha is basically a word that indicates that there is the dryness of the eyes, and that would be incorporated in the eyes of the patient who is suffering from a viral conjunctivitis. So they would be advised the lubricant kind of teardrops. Then the patient can be advised to use the topical antiviral drugs, and weak steroids like fluoromethalones are advised. But we would not advise any kind of high dosages steroids or strong steroids for such patients, because it can flare up the infections and it can further aggravate the situation for these patients. The preventive measures would include the frequent hand washing that would be suggested for the patients, and in any areas in which there is a suspected epidemic of keratoconjunctivitis, we'd educate the patient to frequently, even the normal population, to frequently wash their hands, and no handkerchief sharing should be encouraged in such situations. The isolation of infected individual is done, then avoiding the eye rubbing, as well as you'd ask the patient to disinfect, and just as a doctor, when you have examined such patient, you disinfect all of the eye instruments, whether it is a tonometer, whether it is a slit lamp that you have used to observe such patients. Being a doctor, just to prevent the epidemic to spread, you would disinfect all the eye instruments that were used for such an patient. We have another variant which is known as the non-specific acute follicular conjunctivitis. So whenever we have these cases, we can observe that there are no follicles that are quite evident in these cases of acute follicular non-specific kind of conjunctivitis. No evident hemorrhages are noted down in the conjunctiva, so it's kind of a quite confusing situation whenever we have just a hyperemia and just a congestion that is noted down in the palpebral kind of conjunctiva. Another variant, which is known as the pharyngoconjunctival fever. Sometimes this conjunctivitis is associated with pharyngitis, and it is sometimes preceded with this pharyngitis, and then there is this conjunctival keratoconjunctivitis that is observed in these patients. So this kind of a syndrome is known as the pharyngoconjunctival fever. The features for such a condition are, we have an acute follicular conjunctivitis that the patient is suffering from. He or she will also complain of having a high-grade fever. And then on examination, you would observe that the patient is suffering from the superficial punctate kind of keratitis. That is, the cornea is also involved in such patients. On palpation, you'd observe that the preauricular lymph nodes, they're also involved, and in some patients, the submental and the submandibular lymph nodes are also involved in cases of pharyngoconjunctival fevers. Another variant for the conjunctivitis, which has to be differentiated from the epidemic kind of keratoconjunctivitis, is the Newcastle conjunctivitis cases. The spread of this Newcastle conjunctivitis is associated with the diseased owls. So this is kind of an interesting feature for this kind of a Newcastle conjunctivitis which is observed. The clinical features for such a case of Newcastle conjunctivitis are the types of the acute follicular kind of conjunctivitis. Then these patients would be basically the spread of infections is related to the diseased owls and is caused by the Newcastle virus, which is found in the diseased owls. It is clinically similar to the pharyngoconjunctival fever. So all of those features in which you have the pharyngitis, you have the fever, you have the preauricular lymph nodes, you have the submental and the submandibular lymph nodes palpated in these patients. You have to perform the cytology for such patients to differentiate between the two strains or the two clinical types of the conjunctivitis in such cases. Then moving on, we have another very common variant of the conjunctivitis, which is the acute herpetic kind of conjunctivitis. The causative organism which is usually responsible for such cases is the Herpes Simplex virus 1, and in some cases it is the virus 2 which is responsible for such herpetic infections. The clinical features would include the typical form, and that is basically the lesions of the primary infection. Usually it is more common in the children, in which we have the vesicular herpetic infections, that is in the layman terminology, which are known as the chickenpox vesicles, that are found evident locally. They would be present in the eyelids, on the face, and that would be basically suggestive of the fact that these are the acute herpetic kind of conjunctivitis cases which we are dealing with. And then we have the atypical forms of the conjunctivitis, in which basically it is resembling the epidemic keratoconjunctivitis because of the fact that it is lacking the vesicular herpetic vesicles that were formed due to the chickenpox in the typical forms of the acute herpetic conjunctivitis. Then we have the corneal involvement, which is fine or coarse epithelial keratitis. Sometimes, if they are left untreated, we didn't apply the antiviral drugs and the steroids, the prophylactic antibiotic can be used topically for such patients. It can go on and involve the cornea in these patients, and that would basically be responsible for the fine and coarse epithelial keratitis in these patients. On performing the palpation, we'd see that the preauricular lymphadenopathies are also involved in such patients and occurs almost always for these patients. The topical antiviral drugs are used as a treatment in these patients, a supportive measures that is similar to the epidemic keratoconjunctivitis. That would be basically the use of sunglasses, the cold compresses that are usually advised for such epidemic keratoconjunctivitis cases, and then obviously the use of the topical low-dose steroids that can sometimes be used but mostly avoided in cases of herpetic conjunctivitis cases. Another variant is known as the acute hemorrhagic conjunctivitis, which is primarily dealt in with the hyperemia as well as the follicular hyperplasia, which is quite commonly seen in these patients. The causative organisms which are responsible over here are the picornaviruses, that is the enterovirus type 70, which is basically quite contagious in its origin. It is also known as Apollo's conjunctivitis. It was named Apollo's conjunctivitis due to the fact that Apollo was sent to the space on the same year. So that is why it was also named as the Apollo's conjunctivitis. It was more prevalent in the East Africa and England. The signs and symptoms for the acute hemorrhagic kind of conjunctivitis would include the transient blurring of the vision, and then there would be the pain, redness, and watering that is observed by the patient, and the patient would complain of this mild photophobia that he is suffering from. And then obviously he or she would also be having a lid swelling. So it can be the upper lid that is involved, or either it can be the lower lid that is involved. They can be equally more prevalent for this swelling kind of a blepharitis condition that can arise in patients who are suffering from hemorrhagic kind of conjunctivitis. The signs for such patient would include the mild follicular hyperplasia that is observed, then the conjunctival congestion or chemosis that is sometimes seen. The lid edema and preauricular lymphadenopathy is also observed on palpation, and on examination you would see that the lymphadenopathy is most prevalent preauricularly, and sometimes the submantle and submandibular lymph nodes are involved in such patients. The multiple hemorrhages in the bulbar conjunctiva, they occur in these patients, and they are most prevalently seen in the bulbar conjunctiva rather than the palpebral kind of conjunctiva. The treatment would encompass the prophylactic measures that are taken for the epidemic keratoconjunctivitis. So it's again a contagious disease, and we should basically educate the patient towards the spread of the infection. It can be an eye-to-eye infection, it can be spread through a vector transmission, or it can be spread through the use of the personal products, that the sharing of the personal products can be responsible for the spread of such hemorrhagic kind of conjunctivitis. We usually ask the patient for instilling the broad spectrum antibody eye drops. And then sometimes there is the supportive measures, that all of the supportive measures that were taken for the epidemic keratoconjunctivitis, that basically encompasses the cold compresses, the use of the sunglasses, and the use of the mild steroids that is sometimes indicated in these kind of conjunctivitis cases. Then we have another condition which is known as ophthalmia neonatorum. It's again a condition which is caused due to a viral infection that occurs in the eyes of the infants, that is usually less than 30 days of the age. So this is the most prevalent age group that makes the patient predisposed to such kind of conditions. The etiology for this condition, it can occur basically before birth through the infected liquor amni in the mothers. It can be during birth. A common mode of infection, especially in cases of face presentation or in cases of the deliveries in which the forceps were used for carrying out the delivery of such babies, they are more prone to the development of ophthalmia neonatorum. After birth, during the first bath or soiled clothes or fingers, they are responsible for the spread of infection to the eyes of the infants. The causative agents, the chemical conjunctivitis, it can be a gonococcal infection. It can be the Staphylococcus aureus that is responsible for such infections in the newborns. Staphylococcus hemolyticus or Staphylococcus pneumoniae is sometimes responsible. And then we have the neonatal inclusion conjunctivitis, that is the Neisseria gonorrhea is sometimes responsible. That is, the genital infections of the mothers are sometimes spread to the infant, and that is basically known as the neonatal inclusive conjunctivitis. Then we have the Herpes Simplex virus type 2, which is sometimes responsible for the development of ophthalmia neonatorum in the infants. The incubation period for the organisms, the other bacteria, is almost 5 days. The neonatal inclusive conjunctivitis is almost 21 days. That can be regarded as 3 weeks. Then we have herpes simplex virus 1, that is almost 2 weeks or 15 days. Chemical ophthalmia neonatorum is almost 6 hours after the exposure to a certain chemical. And in gonococcal conjunctivitis, it's almost 4 days of incubation period. The clinical features would be pain and tenderness. Usually it is a bilateral condition. Both of the eyes are involved of the infant. We can observe pain, that the baby is in severe pain, tenderness, conjunctival discharge, lids are swollen of the infant, hyperemia and chemosis is also noted down. And then we have the superficial punctate keratitis that is noted down in these patients. The complications, if it's left untreated or if it is ignored, it can also relate to the corneal ulcerations in the infants. Then obviously the corneal opacifications that can occur. And finally, we have the staphyloma formation, that is a pseudomembrane that is developing on the bulbar kind of conjunctiva that can occur if these patients are left untreated or if the cases are complicated by any way. The treatment would include the antenatal and the natal measures and obviously the postnatal measures. The antenatal measures would be to basically educate the patient towards the, especially to educate the mother before delivery towards the genital infections and all of the safety measures that the mother can be educated towards. And then there are the natal measures, especially during delivery. So the use of the forceps should be avoided as much as possible. And then the postnatal measures, obviously the soiling of the eyes with the contaminated fingers, and the first bath is again very important over here. Previously, we used a Creed's method, that was the installation of 1% silver nitrate in the eyes of the infant just to avoid any kinds of infections, but that is obsolete right now. And that is furthermore not used due to the side effects of the silver nitrate itself. The postnatal measures would also include the tetracyclines or the erythromycin ointments that are used, the single injections of ceftriaxone 50 milligrams per kilogram, and then povidone iodine 2.5% solution for the cleaning of the eyes is used postnatally. Furthermore, there was a Creed's method, as I was already mentioning, the use or the installation of the silver nitrate in the eyes of the newborn. The curative treatment for the gonococcal ophthalmia neonatorum would include the penicillin drops, that is 5,000 to 10,000 units per ml, Then we have a saline lavage that is done for such infants, in which we are predicting that the patient might suffer from such kind of a gonococcal ophthalmia. Atropine sulfate ointment is used, and then we have the bacitracin eye ointments that are indicated or that are prescribed for such patients prophylactically. This is all the ranges of the topical therapies that are available for the gonococcal infections. Systemic therapy would include the use of ceftriaxone, or we can also use cefotaxime for such patients. Ciprofloxacin can be used if there is any hypersensitivity noted down with the ceftriaxone or ceftoxime. We can also use benzyl penicillins in these patients. Then we have a bacterial ophthalmia neonatorum. We can use broad-spectrum antibiotics in such cases, and we can use ointments that have neomycin and bacitracin as a combination. The neonatal inclusive conjunctivitis is basically, the treatment would include the topical tetracyclines, that is almost 1%, erythromycin 0.5% ointments are used. We have systemic erythromycins that are indicated in patients in which we observe that there is some sort of the side effects noted down in a lot of neonates. Then we have both parents to be treated. So it has to be the mother and the father. They both have to be treated because the spread of infection can also occur from the paternal side rather than the maternal side. We have another variant that is basically the herpes simplex conjunctivitis. In such cases, the treatment would be the topical antiviral drugs and the high dosages of the acyl clover. The herpes simplex strain 2 is usually responsible for such infections in the neonates. Again, it's an infection which is bilaterally involving the eyes of the infant. Then we have the granulomatous inflammations of the conjunctiva. The forms of this granulomatous infections, which is basically relating to the chronic kind of the infections that are more prevalent in the individual, are the tuberculosis of the conjunctiva. Then we have sarcoidosis of the conjunctiva, and then we have the syphilitic conjunctivitis. All of these infectious states are basically chronic in their nature. They can be spread systemically, or either it can be the local growth of all of these conditions. That is, can be the tuberculum that is specifically involving the conjunctiva. It can be the sarcoidosis just involving the conjunctiva, or syphilis that has spread systemically to the conjunctiva. The granulomatous inflammations of the conjunctiva include the ophthalmia nodosa. Then we have the leprotic conjunctivitis that is noted down. And finally, we have the conjunctivitis in tularemia. So these are the different forms of the granulomatous conjunctivitis. It can be a nodular form. It can relate to a follicular form. It can be the formation of the papillas or the follicles on the bulbar or the palpebral part of the conjunctiva. So overall, you would have a patient who is suffering from a chronic infection, as well as he'd be presenting in the outpatient departments as follicular, papillar, or hemorrhagic kind of the conjunctivitis. The nature of the disease is again very important, and the isolation of the organism is again very important. For example, if it's tuberculosis or if it is the syphilis, we have to isolate the organism on further investigations and the specific cytologies to confirm the granulomatous inflammations in the conjunctiva of the individual. Then we have the Parinaud's oculoglandular syndrome. It's again a syndromic condition that is occurring, that is involving the viral kind of conjunctivitis. The causes would be basically including the tuberculosis. Again, it's a chronic condition that is occurring in the patient. The cat scratch disease or tularemias, they're responsible. Then we have lymphogranuloma venereum, in which the lymphatic system is infected along with the primary infection of the eye. And then we have syphilis as one of the causes of the Parinaud's oculoglandular syndrome, in which the glands are also involved. The ophthalmia nodosa is another variant in which we have the viral kind of conjunctivitis that is coupled up along with this nodule that raises on the palpebral, or even it can arise on the bulbar part of the conjunctiva in the patients. So in this particular lecture, we summarize the different sorts of viral conjunctivitis. It can range from a typical epidemic keratoconjunctivitis cases to the haemorrhagic kind of keratoconjunctivitis. It can be the non-specific keratoconjunctivitis. It can be the pharyngoconjunctival cases or the fevers that can occur in these patients. The differential diagnosis is very important to note down or to jot down, and then you have to be very specific to get to the definitive diagnosis. You have to carry out the lab investigations in a certain manner, and obviously you're also going to clinically examine the patients in further detail to get to the definitive diagnosis. So that is the end of this lecture. Thank you for watching sqadia.com.